Welcome to our latest episode of the Lebanese Physicians podcast. And today we'll be talking about pay-for-performance in Lebanon with a recent paper published by Jade Khalife and his team, who currently Jade is located in Denmark. And this episode was co-hosted with Dr. MohammadAli Jardaly. Welcome, Jade. Welcome, MohammadAli, to the podcast.
Thank you. It's a pleasure to be here with you.
Jade,
it's good to have you on for the second time.
Yes. The first time I saw earlier was episode 33 about COVID and zero COVID.
This is episode 133. No, I'm kidding. So Jade, so I know this was part of your PhD work, but can you tell us a bit first about how the Ministry of Public Health and started working on pay-for-performance in Lebanon, and how did that come about?
Mm-hmm. Yes, it started off actually not very directly. In 2009, there were different initiatives being run at the Health Ministry, and those were mainly, one was on developing clinical admission guidelines for patients to be admitted to the hospital, in which cases yes, in which cases not. More like recommendations or guidelines, and of course the context and each is case by case, it depends. Another one was utilization review to make better use of the data that was stored in the hospitalization database of the Health Ministry, to understand what are the most common conditions, the most costly, the ones with the greatest length of stay or variations, where were the outliers. So things of that sort. And that just became possible at around 2011 onwards, because the Health Ministry started to systematically collect the data from hospitals, or they began to report it systematically to the Health Ministry in an electronic format. And that opened a lot of possibilities. And the third one was performance contracting, which actually evolved into what we call pay-for-performance. The pay-for-performance model of that was integrated within the Health Ministry in Lebanon. It's the reason for this is actually covered by the first paper in the thesis, which I did part-time alongside my ongoing work, and I wouldn't recommend that, I think, for most people, because it's nice to be able to focus not on too many things, but I took time to develop it, and along the way, I think what I really enjoyed was we were able to develop both the methods and the evidence base for this, and to learn from other initiatives in other countries as well. So the point of this pay-for-performance itself was to improve the fairness and transparency of the model that the Health Ministry uses to contract hospitals in Lebanon. There are about 140 hospitals, 25 or so of which were public and the remaining private. And every year the Health Ministry would contract with every hospital to cover patients that are under the Health Ministry's coverage. Everyone who is not insured in Lebanon is under the coverage of the Health Ministry. That's about 50% of the citizens. So the Health Ministry was acting as a payer and the hospitals as a provider. But the main thing was that the Health Ministry had three payment or reimbursement tiers or levels. And it used to categorize hospitals into their individual tiers or levels, depending on the results of an accreditation process, which happened once every 3-4 years. But both hospitals and the Health Ministry over time realized that accreditation was good, but not enough. And therefore, we needed to find a way to take into account the average risk or average complexity of the patient entering a hospital. Of course, if a hospital has more readmissions than another for certain conditions, it may be that that hospital is doing a worse job, but it could be that it's just having more complex patients, older patients, patients with, let's say, more heart failure or more pneumonia, which is then different than seeing a lot of patients from a younger age group from milder conditions. So we need some way to risk adjust this, and also to make the system more transparent. And that is, I think, was a very implicit goal of what we were doing to um, to um, to improve the fairness and transparency and decrease the influence of political favoritism and clientelism, which is also an important feature of the landscape. So using the data and well described and transparent model to determine those reimbursement tiers instead of other issues or wasta or other, maybe perceptions of what a hospital admits rather than what it actually admits.
Okay, I want to congratulate you, first of all, on publishing your thesis. I know it's a year too late, but better late than never. And it's really amazing that you've been talking about value-based care for what it seems like the past 10 years, when right now it's like a global trend and people are catching on to it. So it's very impressive that this work is coming from Lebanon more than 10 years ago. And just I'm trying to see where pay-for-performance fits into the bigger value-based payment model. So on one end of the spectrum, you have the fee-for-service, which is pretty much the only existing model in Lebanon for the most part, outside of like HIP at AUB or like a few small bubbles in university. But for the most part, I would say the system is based on fee-for-service, correct?
Well, in Lebanon, under the health ministry's system, we have the medical cases are or medical hospitalizations which don't involve a surgical procedure. These are fee for service. So depending on what services and materials that the hospital is going to use for this patient, that is going to be reflected in the actual bill. But the surgical hospitalizations are those that involve surgical procedures, and for those hospitalizations, it's a flat fee. It's a prefixed amount for that actual procedure. So
like
for
a bundled payment.
yeah, you could say bundled in some sort. But it doesn't cover anything outside of the hospitalization itself. No care outside of the hospital or something of that sort. So it is
Okay.
just restricted to the hospital itself, and for every procedure there is a respective amount that then is reimbursed to the hospital. So if you think about it, there's actually more room for abuse or misuse or fraud in terms of the fee for service, the medical hospitalizations. And that is actually one of the things
Okay.
we have uncovered over the years in our work with this. But that is the structure. And of course, there is a small minority of cases, about 4 or 5% or so, which we call mixed cases, and those involve elements of both, of course. And these are typically more complex or ICU patients and things of that sort.
So this is for the Ministry of Health, but what about like Daman and private insurance? How's the payment structure for those payers?
For each of these, there are overlaps in the methods that they use. The private insurance, though, has gone more into or further away from fee for service, and they have their own different models. They there was there in the 2000s. There was an initiative to have more alignment or harmonization across those different payers. But unfortunately, for different reasons, it did not happen. It was a pity. I think at the very least between Daman and the National Social Security Fund, the NSSF, and the Health Ministry, as the two major public payers or two major payers to begin with. In terms of population coverage, we're talking about 85% of citizens under this. Then the private is about 8 or 9%, and then there are some mutual funds and cooperatives, 5, 6, 7%, alongside maybe 2, 3, 4% as well for army security, things of that sort. So the health ministry and NSSF covers the huge bulk of the population in terms of number. but the harmonization did not work, or it didn't happen. And I think that is definitely something that has to be revisited.
Yeah, and the
And then
other
your
issue.
work was only focusing on the MOH,
On the
right?
health ministry, because the data was available at the health ministry and because the opportunity to do this was there. Unfortunately, at the NSSF, it was more, I think, such things are more complex and they had more limitations in terms of how much of the data is coded electronically and things of that sort. But yes, it was just under the health ministry.
And I would say one thing to note between difference between Lebanon and the US, let's say, is that the health ministry in Lebanon, although it covers a lot of the patients, but the payments for the hospitals are not as much, let's say, as Medicare in the US. So when Medicare in the US does a paper for performance, all the commercial insurance brokers follow that. While in Lebanon, it's not the necessary thing to happen because the Ministry of Health, typically a lot of the hospitals or private hospitals do not take ministry beds in the first place, right?
Well, actually, I agree. I mean, on the first part, there is definitely a huge difference between the U.S. Environment or context and Lebanon. In terms of the coverage itself, of the health ministry's hospitalizations every year, which were, say, about 240,000 per year. Of these 240,000, we have about one third happening in public hospitals and two-thirds happening in private hospitals. So there is a lot of relation with the private hospitals, but not so much with in terms of I mean not the private insurance, let's say, or some other private providers. So there are many nuances or details that definitely make the U.S. context very different than the context in Lebanon.
Yeah, so Jade, so basically to get to your study now, so basically what diseases did they cover with the pay-for-performance model, what major ones, and what major ones were not covered?
Mhm. It's a very interesting question because what we wanted to do was for on the one hand we wanted to solve this issue of risk adjustment. We couldn't afford to ignore some cases and favor other ones or only focus on other ones. At least our entire model shouldn't be only on some. We did focus when it came on readmissions on four conditions: stroke, cholecystectomy, pneumonia, and something we call general readmissions, which is basically all readmissions pulled together, because we didn't want hospitals to only focus on the three more specific types and then ignore, the more broader. Well, we don't want hospitals, and that's one of the risks with more targeted interventions. If you over incentivize hospitals or if you incentivize them to focus on certain select procedures, it might come at the expense of other procedures. So you need to have a way to capture the change on other procedures as well, or at least kind of, spread the incentive. So we did it for that, but I would say that the major incentive was really on the case mix index and patient perspectives. But the case mix index itself, we had the problem. What we really wanted to do is we didn't want to just copy what has been done elsewhere. We wanted to contextualize it and adapt the rationale to the Lebanese context. We knew there was a considerable amount of abuse or misuse or mishospitalizations for some types of cases that we had already established by investigations in the past. Particularly for things such as nausea, gastroenteritis, vomiting, headache. Of course, some hospitalizations for these conditions are extremely justified, there's no doubt. But we knew from previous investigations that there was also a considerable abuse in this because the hospitals receive an amount from the health ministry every year to use. And in general, the incentive for a hospital is to admit a less complex case, which is more predictable. That would eat up from the ceiling so it can from this amount. So it knows it wouldn't exceed this amount because it won't get the money usually, and it won't have to get any risk on the hospital's back, so to speak. So there's an incentive to use up these funds for simpler procedures. I'm not saying all or most hospitals do that, but this was a factor we had documented before. And the way we did was because case mix was not included in the system in Lebanon, we included it within the pay for performance, and we gave it a weight of about 40% or so. And so what we wanted to do was, because we introduced this case mix, it was a bit of a shock to the system, you could say. Something new happened. And we had, and what we saw, we actually did two iterations or two models in 2014 and in 2019. The 2019 was an adaptation of the 2014 one. In 2019, what we did was we included readmissions, and we removed some other minor components. But the main ones of case mix and patient perspectives or patient satisfaction remained there.
Can you just explain to the listeners what case mix is? Because I'm not sure everyone knows what it means.
So there is actually a standard formula for calculating the case mix index, let's say. This was something that was started up and adopted in Medicare, Medicaid, and in the US broadly in the early 1980s, because this issue of risk adjustment and comparing, we don't want to compare apples to oranges. We want to compare apples to apples and oranges to oranges. So we want to have some more objective way of calculating what is the complexity of the average patient coming to a hospital. And basically what that means is we get hundreds or thousands or tens of thousands of cases to a hospital. And we want to reduce all of this data into a single number to capture the complexity. And there is a formula to do this, which isn't too complex, but it's important that in every system that you understand how to apply this and how to adapt it, because the formula itself is relatively straightforward. It's how you weigh different cases that is a bit more statistical in that sense. So basically it was, and so if I want to compare, let's say the cost of the average case coming to one hospital versus the other, or readmissions of one hospital to another, I need to, let's say, divide that number by the case mix index to be fair. Because a patient that is has more comorbidities or is older is expected to cost more, for example, or is more likely to be readmitted. So these are some of the things, because before the case mix, for example, you'd get a hospital director, let's say, meeting with an official and saying, look, yes, it's true, our average cost is more, but I have very complex patients. I have heart failure. I have patients who have undergone coronary artery bypass and then you know, what can the official say? He calls someone from the technical department or level who comes up and says, okay, all these conditions are entering, there's this many, this many. It's too detailed. You need to have a very transparent number for that, and there is an approach for that. So that's basically the case mix index, and of course there are various variations of it. The point is to come up with some figure that reflects this complexity.
So Jade, what did you find? So basically, we talked about this. They adjusted it for the case mix index. And I agree with you, because like a hospital like AUB MC, let's say, maybe more of a tertiary care center in Lebanon versus another smaller hospital that gets lower intensity cases. But so what did they find in terms of hospital readmissions for these diagnoses that you mentioned before and after the pay-for-performance model?
So for example, after we had evaluated, I have a slide, but maybe it's a bit challenging to share. I don't know, but I can say it. Basically, what we found two broad things. The two main findings after implementing the 2014 model was that, one, we had a decrease in unnecessary hospitalizations. And two was we had an improvement in the quality of medical coding, coding of ICD-10 diagnoses, discharge diagnoses. Now, for example, when I speak about unnecessary hospitalizations, I will share this to give an example. I had mentioned earlier that we had already documented that there were unnecessary hospitalizations that we had documented in previous reports and investigations done by the health ministry. And basically, this slide shows that we had changes in the case mix index when it came to short or medium-term hospitalizations. But we didn't want to just stop at, this is the slide I'm showing. We can see on the left-hand side there are private hospitals, on the right-hand side public. And as well as short stay cases, these are 0 or 1 day, and medium stay cases at the bottom, 2 to 15 days. And then we have long stay cases, which are longer than 15, which I won't get into now. But the overwhelming majority are these type, short or medium stay. And we found significant changes when we did interrupted time series analysis, which is the proper method to analyze change in this. We found changes in some of these types of hospitalizations. But we didn't just stop at saying we found a statistically significant change, because we want to understand in the real world, what does it mean? And when you want to speak to hospital managers or physicians or on the operational level or in the real world, you want to be able to explain why is it happening, why are the changes happening, and this is something that we did using an algorithmic approach. We were able to explain the changes in the case mix index, and we found different things. For example, intestinal infectious diseases, and in this category, we had a decrease of almost 1,000 medium stay cases, an increase in short stay cases, about 260 or so. We found, for example, for fever of unknown origin, which should be a diagnosis of exclusion, but we knew there was a lot of abuse, and this had decreased by almost 1,000 cases. And now, in some for example, the ones that we found that also for abdominal pain, we had decrease of 2,000 cases of medium stay, an increase of about 200 in short stay cases. So altogether, this picture is painting two things happening. One is that there are less overall cases for some conditions. And these are conditions which are generally less severe, which we have documented in the past from hospital investigations that there is abuse or misuse of hospitalization. The second thing is we're seeing a shift in some of these from medium stay to short stay, which in general is a good thing. We don't want to incentivize decreased length of stay. That's not the point. But this is an indirect consequence of introducing case mix to the system. In general, we can say that those hospitalizations that shouldn't have been hospitalized were decreasing, and there was also less of an incentive to keep the patients longer. There was also a shift towards short stay. The other thing that we see is improved coding, and that we can tell from the change in the coding for neoplasms, because a lot of cases were being coded as for example, breast cancer or a colon cancer or various other conditions, but they were actually coming for chemotherapy. So it was not initial evaluation and workup and more costly procedures at the start, but it was the standard chemotherapy that was happening, which is generally far less costly in our system. So here there was also a very strong improvement in the medical coding. And we know from hospitals and from two universities where private hospitals actually went to them and asked them, can you please prepare training so we can improve the medical coding of our coders, or new coders were trained. So we also had on the ground evidence of things happening and things were set up. And it was something very, very promising at the time. So this is in terms of the changes of the 2014 model.
Can you spend a minute talking? I know like we were already talking about results, but I'm really interested in collecting the data because a lot of like hospitals in Lebanon like are paper-based. So can you spend a little time talking about like how you went about collecting the data?
The good thing is when it came to the work using the hospitalization database, it was already being collected. Hospitals don't get reimbursed by the health ministry unless they have provided the data in an electronic format to the health ministry. And this is what happened in 2011. That became the formal system, and that is why we have this data. Not all public payers have this, and that's the one of the biggest challenges. It should be, of course, it should be standard that that this is provided, and it is not very complex data. This is again routine data, administrative data. This is the kind of data that, at a minimum, a hospitalization database should have.
So one question for you, Jade. Yeah, with the collection of data, I know there's some issues with paper charts and stuff like that. But again, when you start coding better, then it's probably easier to collect the data in that case. But in the absence of EMRs in a lot of the hospitals, it's sort of harder. But so basically, what I heard from you is that one, there's a decrease in readmissions. There's maybe a decrease in hospitalizations for some of the common diseases, and maybe a better quality of care that's being provided, although we don't have the exact data for that. So my question for you is, how did this impact the quality of care of these patients? And number two, did it impact the cost effectiveness, or was there a cost analysis done as to whether this would decrease costs in the healthcare system?
In general, because there were so firstly in terms of quality, when we have tried to introduce different things. One was to incentivize improved patient satisfaction or patient perspectives. And here is, I mean, patient satisfaction in and of itself is an outcome. This was something that was coined in by Avedis Donabedian, very well known in the past, and a lot of work built up on his work also in the US. So we're working on improving health outcomes and patient satisfaction. Patient satisfaction is a multidimensional and complex issue in and of itself, which I'll park at the moment. But that was one of the things we had included in the model. The other thing that we also aimed for was to improve quality in terms of decreasing unnecessary hospitalizations. We don't want patients to be hospitalized when they don't need to be. The hospital is not a place where you would be if you didn't have to be there. Or if it was not medically advisable to be there. So it's that is certainly something we don't want to be abused. And the third thing was, of course, readmissions. Again, we wanted to incentivize hospitals to improve their procedures before discharging patients, whether it be the actual procedures carried out or the actual hospitalization, the treatment, the acute care, or the discharge information. That is another thing. So that is also something that we have tried to incentivize. We did see a decrease in two types of hospital readmissions, cholecystectomy and stroke, but not in two others, pneumonia and all cause or general readmissions. And I think with readmissions, it's quite tricky to work with because ideally you don't want to over incentivize the decrease of readmissions. You don't want hospitals to gain too much or be overly incentivized for that. It happened in the US. And at some point, for some conditions, readmissions, the decrease in readmissions was several more times incentivized than the decrease in mortality. We could see that for heart failure, for example, and there's a lot of evidence documenting different things. So you want to get the programs right. In the US, it's also a bit more complex because you have different programs. You have the HAC-RP for also and the HRRP for decreasing readmissions. You have the value-based purchasing, which also all programs that had started up after the 2010 reforms. And in some cases they overlap. In some cases they're not well integrated. And and some early studies were quite promising about it, but in the longer term it turned out to be not so promising. And I think it would be unethical and unadvisable to repeat the same experiences elsewhere. Instead, we should learn from these lessons of various systems and build and develop better models for the future. So parking it at improved readmissions, improved in terms of unnecessary hospitalizations. The third thing was improved system effectiveness. We were not aiming to decrease the costs. I think any healthcare system, considering inflation and the overall market conditions and various incentives outside by providers and medical devices, pharmaceuticals, a lot of factors. I think it would be far too complex to actually decrease the cost. The costs are going to increase. The question is, how do you regulate or limit that to? How do you, in other words, how can you improve the efficiency or cost effectiveness? And here we were able to do that by
value.
Yes, here we were able to do that indirectly by including the case mix index. The fact that the case mix index was rising, and we could explain by unnecessary, far less severe hospitalizations, showed that hospitals were admitting more complex cases. So in a way, we are getting more services for that amount that the health ministry had. Now, this was only meant to be one step in the program, and there was a long-term vision to continue evolving this into 10 years' time, 5, 10, 15 years' time. But yes, that is where we arrived to. And because of all the changes and the struggles and crises Lebanon has gone through since 2020 or late 2019, most of this is frozen. But
so you started this work in 2014, and it was
2009 actually.
Very encouraging results in terms of pay for performance, and you want to take it to the next level. 2009. Okay, wow.
Yeah. So we did have reap some benefits out of this, and we evaluated it in 2014 and in 2019. But unfortunately, of course, this was meant to be to continue evolving, and we did learn. We did do our best to learn from evaluations of other programs in other countries, and they're very limited in terms of scale. The programs at scale, when we talk about pay for performance in hospitals, there are very, very few examples at scale when we're talking about in terms of hundreds of hospitals or more, because it's very different. You can implement it in 1 or a dozen hospitals and get very good results, but you don't know where the patients are going. Maybe they're going to other hospitals, and then or outcomes are being worse elsewhere. So at scale, things are much more complex. So designing a program fit for 140 hospitals is different than designing it for 1 hospital in some ways. But yeah, so that's broadly.
So where does this leave us in terms of like your policy recommendations? Like it's 2024 now, we're going into 2025. If you had like a magic wand that you could wave at the system to have like the best value-based model in Lebanon, what would your policy recommendation be?
Well, I think the most important thing is to continue where we have left off. a lot of the capabilities are mostly recoverable. A lot of it is able to restart again. The problem is the challenge is, of course, the context. And that's the biggest issue. It's understandable. There are overlapping crises in Lebanon and around, and it is a challenging time for the region as a whole. So, but regardless of that, definitely one should engage in these programs. It's just because if anything, it makes it even more urgent to focus on improving healthcare and health systems. But it is challenging to get policymakers to have this on the agenda. I think broadly speaking, also, we're here a lot about value-based healthcare. There's a lot happening. It's become such a trendy keyword, but in general, it does not work. That's a very important point, I think, that needs to be, or when we at least talk at scale. I'm not talking at the individual hospital level, but at scale, when we're talking at a national system or very large regions, the evidence is not convincing of improved health outcomes. And there are reasons for that. The main one being that they are very focused on outcomes. And outcomes are quite complex. There are social determinants of health. There are determinants of health that are outside of the ability of physicians and hospitals to influence. So we don't want a system where the hospitals working in the most deprived areas are the ones that are most penalized, which is how it turned out also in the US. So that is one of the things also to learn from and to improve. So that is one big thing. It's important we discuss value-based care, and I think it definitely has an important future in it. I don't think it should be the center of a health system. It should be integrated within the health system. Pay-for-performance or value-based care definitely have major roles to play, but we need to keep in mind the externalities and the context, what is outside of the control of physicians and hospitals, and how we construct these incentives. And here, I think the main role should be examining the very core of health systems. What is their focus? Is their focus the patient, the population, or is it something else? And also involving patient perspectives in this discussion in developing health systems.
Yeah, Jade, this was a great podcast. I think we discussed your study, and the interesting part is pay-for-performance in a country that has gone through a lot of crises versus other countries that have implemented this model that are more like economically ahead in that case. But I think, as we said, I think healthcare is very complex. It starts from preventive care to multiple factors, to air pollution, to whatever, sanitation. And at the end of the day, I think we have not figured out the perfect model yet, because you look at Europe, they have a model that people say we want to be like them. And then when you see people in Europe, they say, oh, we're not getting good access to healthcare. We want other forms of healthcare. So I think nobody's figured out yet the perfect model. But I hope your study will lead to a more perfect model in Lebanon for sure. Thank you very much.
Thank you. Thank you. It was a pleasure being with you. And that reminds me, at some point in ancient Greece, for about 200 or 300 years, for around 400 BC or so, as well as in medieval England, around 1200 till 1400 or so, and in China from about 1300 till the early 20th century, they had a model where physicians were usually most physicians were paid to when their patients were healthy, and not paid when their physicians fell ill. Of course, times have changed, but we do need again that emphasis on prevention. I absolutely agree. Thank you very much for having me.
Thank you for being on the podcast.
Thank you.
Thank you. Thank you. We look forward to having you for the third time, maybe to discuss your paper on patient perspectives.
Inshallah. Thank you.